Okay. All right. Well, here we go. Thank you guys for joining me. For those who don't know, I'm Tracy Gary, and I was a former Detroit broadcaster. I got implants in 1998. I had mystery illnesses for 20 years, didn't know. A gal down the lake informed me in 2017 it could be my breast implants making me sick. I removed them in April of 2018. I had over 40 symptoms, massive back pain. I thought I was going to have surgery. The symptoms were unbelievable. They're all gone. Once I removed the breast implants, all my symptoms went away except for some night sweating, but I have Hashimoto's since a kid. So I've been sweating since a kid. So I put implants in on top of an autoimmune disease that I didn't know that I had and created the perfect storm. The problem is implants are now linked to a cancer of your immune system. So women are getting breast implants and then they end up with autoimmune issues from the breast implants. And of course, the medical community denies that, but really, seriously, it gives you a cancer of your immune system. So use your common sense on that. Now, the reason for this is this chat today.
Now, Tracy, if I may jump in.
Sure.
I just wanted to say hello to you. Thank you very much. Now, it's important. I want to go ahead and highlight one very important fact. You got your implants in what year?
1998.
1998. Now, I just want to go ahead and clarify for the record. Back then, in 1992, the silicone implants were banned. And so you could then get saline implants because they were determined to be safe. And so you got what were the safer implants, and they were absolutely not safe. And I just want to go ahead and highlight, silicone implants are bad. You were the victim of saline implants, and you got the same sign symptoms that a patient with silicone implant gets, and the same sign symptoms that a patient with ruptured silicone implants. And so one cannot look at your symptoms, those 40 symptoms, and like you have mentioned before, that I'm aware of, which included suicidal ideation, along with the weight gain and all the inflammation, along with all these problems that you came in with. So it is important to mention that all implants are bad, including saline, and one cannot differentiate the sign symptoms from silicone implants or saline implants, and that both of these should have been banned in 1992 because both of them are associated with these problems.
I agree. And I was told they were safe. I was told they were a lifetime device, that I would be buried at 90 years old and they would be standing up in my casket looking beautiful, and I would look 90, but those implants would still look beautiful, that one set. And then nobody told me that on the box they were supposed to be replaced within 10 years. Every 10 years, you're supposed to have a new set put in. I was never told that. I was told they were safe and they were lifetime. So it's not just the gel filled. I just met somebody who had cancer, a very rare cancer, she said, twice, and they did reconstructive surgery with implants on her. So I, of course, informed her of the concerns I have. But the reason I wanted to have this today was we have BIA ALCL, which is a cancer of your immune system that I just mentioned. But now, in September, I believe it was, they came up with, I might sneeze here. They came up, yep, I'm gonna, Robyn, tell them about the new cancer. Well, oh wait, here goes my sneeze. Oh, I think I'm good. Squamous cell carcinoma, which is, right, a Dr. Khan, a form of skin cancer?
Correct. So squamous cell cancer. So just a little bit about myself. I'm a board certified plastic surgeon by the American Society of Plastic Surgeons. This is the one. I didn't get
through my intro to introduce everybody.
Sure. No, it is important just so
you
that
interrupted me.
It is important to note that I'm a board certified general surgeon by the American Board of Surgery. I did 2 years of burns, and then I did 3 years of plastic surgery, and I'm board certified by the American Society of Plastic Surgeons. So I myself, I've been around cancer a lot in a sense that as plastic surgeon, and also we see in a lot of patients that present with different types of cancer. Now, what is interesting about this FDA warning, this is a report 2 months ago in September of 2022, where the FDA highlighted 16 patients that they put forth in their warning that there was this squamous cell cancer that was directly associated with breast implants. So this was not like a supposed or a association. This was a direct link, just like BIA ALCL, which is the breast implant associated anaplastic large cell lymphoma. This is a direct association with the implants, meaning if the patient did not have implants, she would not have gotten the lymphoma. So this is a man-made cancer. This is an implant-related cancer. Now, also likewise, very interestingly, the squamous cell cancer association, i.e. a direct link with the breast implants, was made. Now, one thing I want to highlight is the textured implants were associated or are associated with BIA ALCL, and hence they were banned by France, and then the US soon thereafter followed the ban. Now, I want to emphasize the textured implants certainly are associated, but also the smooth implants too. So the FDA was very precise in their wording that smooth implants are also associated with lymphoma. Now, going back to the squamous cell cancer, this is a very strange cancer in the sense that squamous cell cancer is not found within the body. This is a cancer usually found on the skin surface, for example, or someone, for example, has, you know, and again, in the medical, the world of surgery, patients will find this around the anal wall or around, for example, the mouth. So meaning wherever you have squamous cells, if I brush against the wall, I'm going to basically scrape off some squamous cells. The endothelial cells or the adenocarcinoma are associated with structures like the intestine, for example, or the oral mucosa, for example, or for example, the squamous cells within the oral cavity, for example, but very unique in the sense that to associate squamous cell cancer with the capsule as a direct association with the implants was very bizarre when I heard of it, because it is, if you think about it, very rare of rare. Now, this was so concerning to me to the point where I actually called the FDA myself, and I had a chance to talk to Dr. Corneliuson. She is the associate of Dr. Bashar, who is the head of the FDA, who's directly associated with implants. And I asked her, you know, you have associations of only 16 patients. Now, they mentioned that this is a alert, a warning to the many surgeons, so that they need to be aware that there is this association and that they should be testing and looking for it, meaning that they should check the capsule, because if it's not checked, then we won't know what it is. Now, the single biggest problem that I find as an explant surgeon, and 99% of what I do on a day-to-day basis is associated with explantation, that is removal of saline and silicone implants, and also residual capsules. The biggest problem that I find is the plastic surgeons are not sending the capsules off to pathology to do the CD30 analysis to rule out the lymphoma, to rule out the breast cancer, to rule out the squamous cell cancer, or rule out any other problems. As you will see, fat necrosis, traumatic neuroma, among other findings, have been associated with capsules, including, from what I have noted, what are incidental findings. So just within the last 3 months, I have had capsules sent where they picked up on breast cancer on a patient. She actually went to Carmanos today to follow up with what is breast cancer that was found within the capsule. Fibroadenoma, which is the most common benign tumor. Another patient that had fat necrosis. And this is where, if the pathologist is not checking for CD30 analysis, we are very likely missing on these cancers because they're going to be underreported. So just to let you know, in my 3 years of training, when I was working with the 12 different hospitals as my fellowship training, I did not send a single capsule off to pathology because there was no indication or no need. And the general notion, unfortunately, is that the capsule will get absorbed by the body. So what if the capsule remains behind? And this is, the body will accommodate / learn to live with this reaction to the implant, and there's no indication to remove it. Not only that, it is actually challenged to remove the capsule, and this risk should not be undertaken. Now, one thing I want to mention before I will give, I let you take it on. If there is any doubt, if there is a capsule that looks suspicious, the CD30 analysis must be done. If there is any fluid, it must be sent to cytology, because if the lymphoma is not ruled out, we will not know what it is. And it is malpractice, it is bad medicine if the capsule is not entirely removed, if there is lymphoma that is noted on pathology.
I agree. I agree. Well, speaking of cancer, Robyn, you had breast cancer, right?
I did. I was diagnosed with breast cancer in 2017.
So tell your story so I don't tell it for you, because I'm horrified by your story.
Yeah. So
Especially like watching Christina Aguilera, I don't know if Wendy Williams ever had cancer. I don't think she did, but Christina Aguilera, I find very concerning right now that it may very well be part of that could be her implants.
Yeah. So I was diagnosed in 2017, and this was my third cancer diagnosis. So I just wanted to get it over and done with as quickly and easily as possible.
Your third breast cancer diagnosis?
No, my first cancer was at age 23. I had Hodgkin's lymphoma. And then over the years, I had had basal cell carcinoma 4 times, only where I had really bad radiation burns, because the radiation that I had caused a lot of tissue damage. And then in 2017, I had breast cancer. So I chose to have a double mastectomy. I caught my cancer very early. And
how did you catch your cancer, Robyn?
It was on a routine mammogram.
Yes. So I just want to highlight again, very important. The most common is a self-monthly breast exam. And I want to alert the listeners, do not underestimate the value of the mammogram, because it picks up on these calcifications before your hand even palpates a mass, because sometimes that might be too late. So mammograms have saved millions of lives all over the world. Do not underestimate the value of the mammogram. Please go ahead, Robyn.
Yeah, I couldn't feel my lump. It was only caught on the mammogram because it was pretty deep. So I chose to have the double mastectomy, and I really wasn't interested in reconstruction surgery. I just wanted to be done. I wanted a one and done, but that wasn't offered to me. I didn't even know that I could ask for it. It wasn't offered to me. I was basically asked what type of reconstruction I wanted. So it was kind of implied that this is what you do when you have breast cancer and a mastectomy, you do reconstruction. So I had tissue expanders for 3 months and then switched out to breast implants. And I just got so sick right away. I mean, within a month of having the implants, I had over 24 symptoms. So
within a month.
Oh, within the first week, it started with headaches, migraines, heart palpitations, dizzy spells, difficulty breathing, difficulty swallowing. I would get rashes on my chest, rashes on my legs. My hair started falling out. My eyelashes started falling out. And I didn't do any other treatment for my cancer. I didn't do chemotherapy. I didn't do radiation. I didn't take any hormone therapy. So I couldn't figure out why I was so sick. And I actually turned to breast cancer support groups because I didn't know where else to turn. I had gone back to my plastic surgeon 4 times with complaints of pain, insomnia. I was 44 years old at the time, never had insomnia or sleep problems in my life, never had anxiety or depression. I was feeling anxious all the time. My heart was racing. And her solution for me was she gave me pain pills, sleeping pills, muscle relaxers, and seizure medication.
Oh, seizure medication. That's a new one.
And it just, something wasn't right. And I just did not want to take a bunch of pills. I wanted to feel better. I wanted to feel good, like I felt before I was diagnosed with breast cancer. I was walking 5 to 7 miles a day. And with the implants, I couldn't even walk to my mailbox. So it was through another breast cancer patient that I found out about breast implant illness. And as I started doing research and joined like the online Facebook groups, I was shocked. And I was more shocked and angered that I went back to my surgeon 4 times And she didn't tell me any of this. My oncologist didn't tell me. My breast surgeon didn't tell me. My plastic surgeon didn't tell me. I had an entire team of doctors that failed me.
Yes, no, I want to mention, you mentioned a lot of things, Robyn, if I may clarify. You know, the single most important group of doctors who directly deal with implants are the plastic surgeons. Now, I will tell you, as a medical oncologist, radiologist, interventional radiologist, they are part of the breast center, the medical oncologist. All of these doctors, they are not aware truly of what is breast implant illness, even though they technically meet with them. Now, it doesn't take much. Remember, in 1992, the ban occurred. So we knew, if you go look back at the symptoms in the 80s, late 80s, these are the same symptoms what you're mentioning that the ladies went through. So it's not like we didn't know it's a new illness. No, we knew about it. The doctors knew about it, but more so the plastic surgeons than anyone else. Now, I'm going to say this as a board certified plastic surgeon. If a lady gets breast cancer, unfortunately, 90% of these ladies, the answer is augmentation. And augmentation with silicone implants almost always, or saline implants, depending on the choice. Very rarely will a patient want to do a deep flap, which is a deep inferior epigastric perforated flap, or a latissimus flap. They might do a flap, meaning using the body's own tissue to rearrange and kind of give volume to the chest. And going back to the point, you don't have any lymph nodes that were positive because it was caught very early on, thanks to the mammogram. And what you went through, I just want to go ahead and clarify what you mentioned for some of the ladies who are not aware. You went through what is the tissue expander. So what happens is this general surgeon comes, they do the mastectomy, they remove the breast tissue, and then they do a sentinel lymph node. And then what they do is then the plastic surgeon comes in, makes a cut in the pectoralis muscle, and then introduces the tissue expander, and they put in 50, 70, 100 cc's of saline directly into this tissue expander and then close the muscle. Then you, just like every breast cancer patient, went to the plastic surgeon, and every month or 6 weeks, they would put in 100, 120 cc's till the muscle would expand. And then you would feel the tightness and say, stop, this is uncomfortable. And then the plastic surgeon would say to you, come back in another month or 6 weeks. And then you would come back again. And because the muscle would now have stretched, atrophied, weakened, because remember, you truly cannot use the muscle. If you would use your muscle, remember the muscle sits on the whole chest and inserts into the humerus. If you would use your muscle, guess what? You would push the implant against your chest and it would be an awkward feeling. So already your pectoralis major was compromised. Then 3 months later, you had, I guess, 3 serial expansions, if you will. The tissue was expanded. And now once it equilibrated and normalized, you then went to the operating room, and then the plastic surgeon took out the tissue expander and put in what is the implant that you had, which is of silicone or saline, which will very likely silicone, the one that you got. Now, I just want to mention, in the vast majority of the patients who have cosmetic procedures, and where over 90%, 95% of the times the implant is introduced, it is put directly underneath the muscle in 1 hour, or for very quick. And there is no serial expansion, because remember, this is cosmetic. And so what happens inevitably is part of the implant, maybe 300 cc's, 350, is now covered by the muscle, which is cut. And the other half, or 2/3 of the implant, now hangs below the muscle, because over gravity, and when especially the flexion extension of the arm occurs, it pushes the implant down and out. So you will find many of the ladies will have their implant that migrates down and out towards the side, especially in those patients with the cosmetic procedure. Now, the point I'm trying to make here is you already have a displacement of the implant simply because there is no mesh or eloderm or suture or anything that's holding it, because over time, everything gravitates down. Now, this becomes critical because as a board certified plastic surgeon making a cut in order to remove the implant and capsule, I make a cut right in the crease. Now, I am going parallel to the muscle. I'm not going up and down. And this is a very important point I just want to highlight so that your listeners, our listeners, can see why the cut in the crease is made, kind of a smiley face right in the crease rather than up and down, because you want to be parallel to the pectoralis major and directly underneath, so you don't compromise the muscle. And that is very important. So I just wanted to use that and help clarify that what you said, that you went through the tissue expanders, because many of the patients ask me, what is a tissue expander? My friend got that, how come I didn't get it? So I just wanted to clarify.
Painful, right?
Very painful. Yes.
Extremely painful.
I was not shown what a tissue expander was, what it looks like, how it works in the body. For me personally, it was, I have a pretty high threshold for pain. It was an excruciating process for me. And perhaps part of that was I had some prior radiation, from my first cancer at age 23, but it was very uncomfortable. I actually almost quit halfway through and, was just encouraged to stick it out. I'm almost there. It's going to be so much better with the implants, which was ironic because they were 100 times worse.
Yeah.
So you had, Robyn, you had radiation to your chest before because of the
Not for
basal
my
cell?
breast cancer, for
Oh,
my,
for the Hodgkin's.
Yes.
Got it. Okay.
Yep.
Yep, got it. Okay. Now I will tell you, this is a fact. Now, if ever I am not sure, I will say I'm not sure. But a patient that has received radiation to the chest, and probably Robyn, you know this, who receives implants, the complication rate is anywhere from 30 to 50% as far as dehiscence, infection, contracture, amongst the many other problems that radiation will cause to the skin, plus the implants, because the skin changes for the worse. It becomes more leathery. It is not an environment where you would want to put in implants. So that is very defined, that is very well published and established in medical and surgical literature.
and they're not telling breast cancer patients that information.
Right. Now, I will tell you, I myself, as a board certified general surgeon, there are so many patients, look, they get immediate reconstruction with the implants. Then the lymph nodes come back positive. Then they're told you need radiation and they already have a tissue expander inside. And then they radiate an already tissue expanded, i.e. chest, which sometimes causes contracture, sometimes infection because of the chemotherapy that is almost always required. It decreases the white count. And now because of the infection, because of a foreign body, there is a hold in treatment of cancer because of the aesthetics now is given priority, which is a big shame. This is where I have seen patients who unfortunately their chemotherapy was put on hold simply because they didn't want to lose the tissue expander.
Right. Yes. And it's, the patient's health and safety should come first. And time again, I don't see that happening. It's all about aesthetics. Even if you go back and look at the manufacturer's own original surveys that they sent out for patients that were enrolled in their trials, the questionnaires that they sent out were typically asking about aesthetics. Are you happy with your breast? Do you like the way your clothes fit? Is your sex life okay? But nothing about the patient's health. And that's really where I felt like in my situation, that information was lacking. And, I'm really big. I'm a big advocate for informed consent, and it's become my passion. I passed an informed consent law here in Arizona for breast implants, and we're working on legislation in several other states as well. It's important. And, the
Tell them what the legislation is that you're trying, because I think it's very important, because there are people standing in front of it. And I think they should be ashamed. Seriously, they should be ashamed for trying to stand in front of this legislation. I don't understand anybody having an issue with this.
No, please tell us about the law that was passed in Arizona, because that is important.
It is important. So in Arizona, I basically wanted every woman that's receiving breast implants in Arizona to know what I wish I was told. So I actually developed a patient decision checklist, and I started working on the checklist before Tracy and I went to the FDA in 2019. I actually brought copies of the checklist with me to the FDA passed them out to whoever would take them, because at the time I didn't know who key players were in the industry. So I started working on it way back in actually 2018 and early 2019. That's when I started working on the legislation in Arizona, and the patient checklist has kind of evolved over the years. We worked on it with a working group in Arizona. And then I actually, our GPAC organization partnered with the American Society of Plastic Surgeons, and we worked really hard on it for many months. And I'm proud to say that the American Society of Plastic Surgeons adopted our patient checklist. They even put it on their website. It's still there today. But unfortunately, the FDA rushed and put out without any input from any patient advocacy groups that I'm aware of, they went out and put their decision checklist that they're requiring from manufacturers. So, it's unfortunate because our checklist that we use here in the state of Arizona and that we're going to be using in other states is more detailed. It gets into defining things like the symptoms of lupus, fibromyalgia, Hashimoto's, rheumatoid arthritis. Some women get an informed consent that lists those things, but I'll be honest with you, a typical 22-year-old woman or 30-year-old mom, she doesn't know what signs and symptoms of lupus is, or connective tissue disease, or fibromyalgia. And so they just initial their informed consent, and they're not truly informed. The plastic surgeons aren't having that conversation with the patients. They're just not. And if they're not going to have that conversation with the patients, then they need to be mandated to do so, because those patients deserve that information. Not only because it's the right thing to do, but if patients do start to get sick, they can go back to that checklist and look and see, oh goodness, these are some of the symptoms that I read about when I was getting my implants.
Right.
Because Tracy, of all people, knows that most of the women in our community have suffered for years, even decades. Sick, going
And
from
some right out of the gate. I
Yeah.
was right out of the gate and it lasted 20 years. You don't connect the
20
dots. Huh?
And Tracy shouldn't have had to suffer for 20 years.
Right.
One of my other biggest passions is getting the FDA to let not just plastic surgeons know about this. It's the rest of the medical community, rheumatologists, pulmonologists, cardiologists, all of these different doctors are still not aware of this information. The FDA has not issued an alert to let the medical community know. So Tracy, how many doctors did you have to go to?
I probably went to 6, 7 different doctors. I went to a back specialist thinking I was going to need back surgery, and he couldn't find anything wrong with me, told me it was all in my head, and then gave me a shot in my L4 area in my lower back. And I'm thinking, well, if you think this is all in my head, why are you giving me a shot in my back?
Mm-hmm.
But it was the most brutal lower back pain. It felt like my back was absolutely broken for years. I couldn't roll over in bed in the middle of the night. If I woke up, I could not even move. I'd have to sit there, and then I'd put a pillow over my head so that my husband wouldn't hear me. And I'd have to 1, 2, 3, and I couldn't do it. Like 1, 2, 3. Oh, it was awful. He'd have to pull me out of bed, and I'd be crying in the morning. And
I mean, I know women that have seen over
I haven't
20
had it since they took the implants out. It's completely gone. Women that what?
that have had visited over 20, 30, 40, 50
Oh, yeah.
doctors trying to figure out what's wrong with them.
No, I want to mention one thing. If you ask me, what do I know about rheumatology? I'm going to say very close to 0. What do I know about measuring or treating blood pressure? 0. I've never treated because there's contraindication for some medications. If you ask me about managing diabetes, I will be very frank. I do not know. It's not my specialty, right? There's so many different classes. Now, I will tell you, all these docs, the rheumatologists, the endocrinologists, the allergy immunologists, cardiologists, have they ever even touched the breast implant, let alone saline or silicone? No, I wouldn't expect them. So you're absolutely right, Robyn. We need to, i.e. the administrative societies and the society in general, teach these gateway physicians, be it the emergency room doctor or the family medicine, that there is such a thing called breast implant illness, and that it indeed does exist. And you have to let the plastic surgeon figure it out. Plus, they themselves need to kind of attend courses or lectures, whatnot else, because, you know, this is a real problem with a real solution. Now, one thing I want to mention here, Robyn, that you mentioned, this is according to the FDA, right? And I want you to basically affirm this. If a patient comes to me or a patient goes to a plastic surgeon and says, I want breast implants, the plastic surgeon must discuss three things with that patient. Number one, the implants are not meant to be in the body forever. Number two, that the breast implants are associated with BIA ALCL, lymphoma, and cancers. And number three, that there is such an entity called the breast implant illness, that from the psychological effects, neck and back pain, autoimmune issues, you know, the dryness of the eyes, you know, the endocrine problems, that there is once the implants are removed, that there is a complete resolution, quote unquote, of these symptoms. So the plastic surgeon has to discuss, and I will tell you, there are so many patients, this past almost 2 years ago, there are so many patients that I myself have taken care of where there is no active discussion and no informed consent, where the patient truly understands, or there is no frank discussion between the plastic surgeon and the patient in regards to the detrimental effects of breast implants, both silicone and saline.
Right.
Absolutely. And, you know, it is unfortunate because when the FDA announced this in October of last year about this patient decision checklist, there's no legislation behind it. There's nobody policing surgeons to give this information. And I can't tell you, I have already had dozens of women come to me that have gotten implants since the beginning of 2022, and they tell me their doctor gave them nothing.
Right.
So, or maybe they got their implant card. And so, you know, and I'm sad to say this, but it has to be mandated. It has to be mandated,
yes.
and there has to be a consequence. You get your medical license suspended, you do it again, it's revoked.
Yeah.
Because if they're not doing
We took an oath to do no harm.
Exactly. Yeah. So I'm very passionate about that. And you know, it's unfortunate that we have to work so hard just to get the information into the patient hands, because it really is their right to have that information, to know what's going in their body, to know what it's made out of, and just to know what the risks, and just make an informed and educated decision. It is no different than smoking cigarettes, right? We all know that smoking cigarettes can cause lung cancer. Does every single person who smokes cigarettes develop lung cancer? No. But every time they light that cigarette, they know the risk. They were aware of the risk, and they made an informed decision and chose to do it anyway. So, but if you don't even know the risk, and then you're being lied to, and the FDA is withholding this important, crucial medical information from the entire medical community, this has been going on for 60 years. I mean, this has been really common since the Dow Corning, 1990s. Why are we still running across rheumatologists, cardiologists, pulmonologists, endocrine specialists that have no idea breast implants have this effect on the body systems? It's not okay. It needs to be blasted out there so that doctors can help patients in a timely manner. How many patients have gone undiagnosed with a cancer? This squamous cell carcinoma is a very aggressive cancer.
Yeah.
And unlike ALCL, it does not typically stay in the breast implant capsule. It spreads. It spreads to the lymph nodes, it spreads to the organs, it spreads to the tissue, to the breast tissue. I mean, this is an aggressive form of cancer. And I watched a presentation from Dr. Scott Glassberg from the American Society of Plastic Surgeons. He's the former president. He presented on SCC at the Breast Implant Health Summit this year, which you were also on, Dr. Khan. And, he told us this is a very aggressive cancer and it doesn't respond to chemotherapy or radiation. That's
and 42 or 43% of the patients were dead within 6 months.
Yeah,
within 6 months.
Yeah, those cases.
They're not informing people.
Yeah.
See, the most important thing is the capsules must be sent to pathology, because if it's not being checked, this cancer is being missed. And we all know a fact that the BIA ALCL, the squamous cell, all of this is way underreported. And they said there is some publications that mentioned that the peak is going to occur in 2026. Now, we have to also talk about the risk of silent rupture as well. Look at the manufacturers. Remember, Tracy, you were with me almost like a month ago, and I read the Mentor ad itself, where they said in order to detect for a silent rupture, you have to get a MRI at year 3 after augmentation, and then every 2 years they're onward. And then after 10 or 12 years, the rate of rupture starts to go up significantly high. And this is where, you know, the symptoms, the breakdown of the implant starts occurring and the patients start reacting. And certainly they're coming forth in the masses, in the hundreds of thousands. And so this is very important to mention, that someone has a change in their exam, then they have to seek consultation by a board certified plastic surgeon who agrees and understands breast implant illness. Now, this is what I say. If a patient comes to me and says, I need to get my implants removed, they are 13 years old, the general unfortunate answer by the plastic surgeon is, well, you look good. Why? If it ain't broke, don't fix it. Live happily ever after. And this is a serious problem, because remember, it may look fine now, maybe a year later or 2 or 3 years later, the rate of rupture starts going up significantly. Now you have to deal with a rupture and silicone within the chest. And if it ruptures, it is very hard to remove. And so this is, again, the problem that I find, that the patients come, oh, I was fine for 20 years. Now all of a sudden I'm having pain. Why are you coming now? Or another lady, she was 33 years into her augmentations. She lived through the Dow Corning. And I said, well, you had a chance to remove. She said, I actually signed a waiver in 1992 that I did not want them removed because I really liked the way I looked. And now she comes because she has a grade 4 contracture and a rupture, because now the implant finally ruptured for her and she just couldn't bear with it. And she said, I just want my health back. Now for her, it was these many years later. Who knows, this might have been going on for the last 5 years, 7 years. As you are aware, the many Facebook Lives that I do, there was a case I did just 7 years into her augmentation. She had a rupture. It was a silent rupture. I didn't know about it, neither did the patient. Her exam was very unremarkable, and she was just 7 years into her augmentation and she was hurting.
That's
So
such an
now one
important
thing,
point.
Tracy, please go ahead, Robyn.
Well, you know, there's so much conflicting information coming, especially from the other Plastic Surgeon Society, you know, that it's not necessary to remove capsules. I mean, they were just talking about that with this new study that came out, but then the FDA announcement just completely dismissed that study, because how can you say it's not necessary to remove capsules when that's where the cancer is developing, in the capsules?
Right.
So, but that's
How are you gonna pick up? Yes.
yeah, and
Good
it's so unfortunate that the actual leaders of a plastic surgeon society would dictate that, and
Right.
and you know, that's frightening to me, and it's very dangerous.
So what you mentioned, Robyn, is very, very important. I want to just highlight, this happened just today, Wednesday, the 16th. My patient came from the Netherlands, so all the way from Europe. She saw me, she followed me on Facebook. She had textured implants put in Europe in 2012. And in 2020, she had the implants removed because of the many symptoms of what she was BII. Her plastic surgeon did not believe and does not believe in breast implant illness. So he removed the breast implant alone, leaving the capsule behind. Now she continues to linger with these many symptoms of breast implant illness, where to the point where she said, I'm tired of taking these medications like Band-Aids that suppress the symptoms to an extent or make me sleepy. She's fatigued along with the many signs symptoms. The other thing is just wait and do nothing. And she's been through a lot of other doctors and tests and whatnot else, which all yield even an MRI that there's nothing wrong with the chest. Today, I did her surgery. This was the residual capsule. 2 years later, I removed. It was a very much intact capsule directly on top of the rib underneath the muscle. And it was a challenge to remove in this young lady, a 29-year-old lady from the Netherlands. And this is the biggest problem I, as an explant surgeon, am facing right now. There are so many surgeons who do not believe in breast implant illness. Number two, there are some plastic surgeons who want to be politically correct and say, of course, I believe in breast implant illness, but at the same time, they're augmenting. And I'll tell you, it's you cannot have it both ways. The third thing is, well, the third group of plastic surgeons, okay, I don't believe in breast implant illness, but I will offer you the surgery because you know what? I can do the surgery. Now, when the going gets tough inside the operating room, the surgeon himself or herself says to her ego, I am going to leave the capsule behind because I don't want to risk her life. I don't want her to get any more thorax. So what if 20% or 10% of the capsule remains behind? I will cauterize it, or I will pulse lavage or irrigate it with 3 liters or 5 liters of saline. That's not good enough. The capsule itself has to be physically removed, eliminated, deleted, basically dissected off of the rib, such that there is no capsule remaining behind, because that is what it takes for the patient to bounce back to normal state of good health, minus these toxins. Look at pathology after pathology report. You will see there are breast implant particles, there are capsular debris from basically within the capsule. There's debris from the implant breakdown that continues to hurt and haunt and cause the silicone toxicity because of this gel bleed phenomenon. And now, despite removal of the implant, you have what is silicone that remains within the capsule that continues to hurt the patient. So it is imperative, this is the whole essence of explant surgery, that the surgeon needs to wholeheartedly, sincerely believe, number one, that breast implant illness is real. Number two, that the recovery of the patient lies in removal of the implant capsule plus all inflamed tissue directly off of the rib, which is the hardest part of the case, and to remove any masses, any abnormalities, and send it off to pathology so we can rule out the squamous cell cancer, lymphoma, breast cancer that was diagnosed in my patient a couple of weeks ago, for example, or any other problem, so that the patient has a peace of mind that there is nothing inflamed remaining, and that my surgeon wholeheartedly took out all the capsule because he believes or she believes in breast implant illness, and now the patient has a fair chance to bounce back to a normal state of good health minus all these toxins. And that is what is explant surgery.
Absolutely. And important to point out also, we have had patients whose doctor did not think it was important to remove the capsules, so they removed the implants, left the capsules, and those patients were diagnosed with ALCL years later. 1 year later, 2 years later, and 6 years later, because those capsules were left in.
Yep.
Right. So if you look at my Facebook group page, I just posted for the discussion that we were going to do today, Robyn and Tracy, I just posted this case report that you just mentioned, and many of the cases where the implant was removed, the capsules remained behind, and now in the case report, 4 years later, the patient developed the BIA ALCL, even though the patient has no implant, because the capsule remains behind and the capsule was not tested. And that is a serious problem. Yes. So good point, Robyn. Very nice. This is important. So the capsule, what is the worst thing that's going to happen if the capsules are sent? Nothing. You at least have the peace of mind that there's no cancer, because we won't know. And that's why it's underreported.
Have you always sent to pathology?
So from the very beginning of time, I have always sent to pathology because I won't know. I cannot grossly look at any tissue and send. So today's case, the same lady from the Netherlands that came to me, I found a small mass, which I knew clinically is consistent with a lymph node. I send that off separately because remember, if there is any tissue, the lymph nodes basically harbor the malignancy or whatever, because they're the first set of cells where so that we can rule out cancer, because it may not be in the capsule, but it may certainly get picked up in the lymph node. And not only that, I send 100% of the time the capsules off to pathology to rule out the BIA ALCL, rule out malignancy, squamous cell, CD30 analysis. I take cultures for aerobic, anaerobic, and fungal. And you'll be surprised, 10 to 15% of the time, I have cultures that come back positive for bacteria. 3 of my patients, their cultures came back positive for mold. And I always send these patients with the mold to infectious disease so that they can get complete workup. And then I always return the implants to the patient. I always take a video and pictures, high definition of the chest,
Wow.
showing complete removal of the capsule. And I do the twilight anesthesia, which is basically no general anesthesia, no paralysis. The patient is literally like a colonoscopy sedation. To date, not a single patient has woken up. The patient protects her own airway, and the risk for clot DVT is essentially none. And this is what is very safe, effective anesthesia. And the other thing I do is, as you and I have discussed, Tracy, in person, this is not the time where the dissection is done at the level of the rib, if you will, the basement of the house, which is the hardest part of the case, underneath the muscle, which is where most of the implants are. And this is not the time to be doing a lift, which is all at the roof of the house, or at the surface, at the nipple areola, when the breast tissue is very inflamed. So this is how I do it. And I've done it consistently without the need for drains. So this is very important. The last time I used drains was almost 2.5 years ago. In any of my patients, be it saline or the many patients with silicone implants, even the 800 cc's, and even with the many patients with the ruptured silicone implants as well.
I have to say, you're one of the most passionate breast implant illness doctors that I've ever crossed paths with. We've got a lot of passionate doctors, but honestly, I think you're one of the most passionate. In fact, it was in my intro to you, which you're so passionate, I didn't even get to introduce you, that you paid your own money out of your pocket to run ads on Detroit television, which just blew me away, to warn women about breast implant illness. And then I saw you go on channel 4, I think it was, 1 or 2 different times, I don't know how many times, to just go on and warn people about breast implant illness. Also, you've removed butt implants, haven't you? Can you talk about that?
So calf implants. Now remember,
Oh, you've removed
the
calf?
calf implants. I have removed chin implants. Now the buttock implants I have not removed.
They're very
But
difficult,
I
I
have
hear,
seen,
because
I have the patients have not come my way. Most of the times I find that the BBL, what they call the Brazilian butt lift patients, I've managed, because I have never done. So I want to make sure, and I want to go ahead and highlight to my patients and anyone who's listening, the Brazilian butt lift is a dangerous operation.
it's banned, right?
Yeah. No, it's not banned. Believe
I
it or
thought it
not.
was banned in some countries.
In some countries, that is true, but in the US, believe it or not, it's a very popular surgical procedure.
Oh,
Now, so this is again for the record. The BBL operation is the most dangerous plastic surgery procedure done by a board certified plastic surgeon, period. Number 2, it is replete with problems, including infection, loss of sensation, fat necrosis, which means that 40% of the fat almost is going to die. So if there is injection of, let's say, 300 cc's, 500 cc's, 40 to 50% of the fat is going to die, and the patient is going to have clumps of irregular matter. Now, this is the most deadly operation that is done by plastic surgeons, to the point where at one time the mortality, the fatal rate, the death rate was 1 out of 3,000. Then there was a consensus by the plastic surgery societies, and they said and concluded that, you know, the fat that is put in sometimes can go into the bloodstream and then travel and affect the lungs and cause death as a result, what they call fat emboli. So they came up with a consensus about safer ways. Now, I will tell you this, and I say this very humbly and very professionally, the Brazilian butt lift, which is essentially fat grafting to the buttock area, is the most dangerous operation still. It should be banned in the United States. Any professional, honorable plastic surgeon must not do this procedure. It carries with it still a lot of risks, and it is not worth doing it for the many patients who unfortunately are young and naive and truly don't comprehend the risks of the procedure. And if you ask me, the plastic surgery societies and the board of medicine should step up and actually ban these procedures. If you ask me, that would be the absolute right no-brainer thing to do.
I thought they already had banned them. I'm disappointed.
No.
I thought they already had. Can you just tell me, you just said that it can travel the fat that they're, so like we have women that get, their breast implants removed. And then they get
Yes,
the
yes.
fat sucked off of the, their stomach and butts and everything. And then they have it injected into their breasts to plump them back up. And I have a friend of mine that does that after her breast cancer, and she loves it, but I almost did it. And then of course, the support pages, I love support pages. I love all of our breast implant support pages. And then one of them was a fat transfer page. And I read all these people who loved it, but then I read all these other people who had complications from it. And it scared me so bad, I decided it wasn't for me. Plus I can't handle pain. Robyn's good with pain. I am not good with pain. I'm the biggest wimp. So that changed my mind and I didn't do it. But are you under the impression, or do you think that when they're injecting that fat, is that also capable of traveling to the lungs and stuff like the Brazilian butt lift injections?
So absolutely, the risk is there, relatively speaking, less so. Now,
and most of it doesn't hold anyway. It gets
correct.
absorbed, and these women end up, and it's brutal pain. I mean, the
It's
liposuction.
expensive.
Yeah,
It's
a gal,
expensive.
I was down in Costa Rica and the gal across the hall had done it, and he lipoed her whole, the back and everything. And we shared a taxi to the hyperbaric chambers, and she was in the most excruciating pain, and she was all doped up. And she couldn't even hardly walk. She was in so much pain, and then it didn't hold.
Yeah. No, I'm going to say this. I'm going to say this, Tracy, and let's talk about this in a little bit more detail, because this is a very, very important point. Fat grafting to the face, Coleman technique. You inject 3, 5, 7 cc's of fat into the cheek area, and you do a fanning technique. 30% of the fat dies. Now, the best blood supply in the whole body is on the face. So remember, we want the blood supply to be in and around this fat that is being spread out and fanned and thinned out, such that it will take on the face, 30% of the fat dies in the best of the hands. Now, if you take the same fat, maybe inject into the breast area, you are looking at 40% to 50% of the fat is going to inevitably die, especially in these patients who have breast implants removed. Remember, this is an inflamed area. Now you have fat, let's say they inject 150 and say 40%, let's be generous, 40% of the fat dies. Now, guess what? You have 150 cc's is not a lot. If you look at a Coke can, it's roughly 360, 375 cc's. So it's not much. So now you have almost half of the fat that's going to die. Now, I myself have seen patients, including this patient that came from the Netherlands today. She had fat grafting. If you felt her chest, she has these clumps of fat necrosis. That fat that's scattered all over the chest. Now, I will say this, and I'm going to make a very bold statement. It is malpractice, bad medicine, where 1 out of 8 or 9 women who are going to get breast cancer, who feel the most common way to look for breast cancer is to check for a mass. And now she has a distortion of her self-monthly breast exam because of this irregularities, nodularities, sensation changes, and you have parts and areas of fat necrosis that will linger on years and years later for almost 70, 100 cc's of a volume, where breast cancer now is going to be missed because this lady is reluctant to get a mammogram because it hurts, or she gets a mammogram and now what are these irregularities, calcifications, or abnormal masses that are now picked up. Now, sometimes you can tell fat necrosis on an MRI, but now that becomes a challenge for the patient. She will inevitably miss a breast cancer mass because she might think this might be fat necrosis. And now, again, what Robyn was saying earlier on, and what you were alluding to earlier, in the name of cosmesis, breast cancer, 1 out of 8 or 9 women who are going to get breast cancer in the United States, their self-monthly breast exam is altered, is not to the point where the patient will be able to get a self-monthly breast exam. And now the patient may have delayed breast cancer or undetectable, or she may just choose to delay till it may be more advanced. And now the patient is getting radiation or chemo. Because anyone who can deny whatever I just said, I want to challenge them. I want to take them for a debate. I want them to challenge whatever I just said, because this is common sense. Don't tell me it's safe. Fat grafting is not safe. I will say fat grafting to the face, go for it. Still it's dangerous, but what you get is an excellent, beautiful result, because this is permanent. You don't have to get fillers every 4 to 6 months. It works, and it works beautifully. This is what I would say truly has changed the way aesthetics to the face has been practiced. But fat grafting to the chest, absolute no. Fat grafting to the buttock, absolute no. And this is what my stake is as far as fat grafting goes.
Robyn, thank you, Dr. Khan. Robyn, I'm very proud of you, because you never need to get a mammogram now. And I want you to tell everyone why, because I think this is another very important option that women are not told about. And Dr. Khan, I've seen you do, I think you've done flat closures but on women, but I've seen you do breast reductions on men who had, what is that called?
Gynecomastia.
Thank you. And I've
if
seen your before and after pictures. I thought a couple of them were women. They had breasts like women, and by the time you got done with them, it was the chest of a man, and it was really quite impressive. So, Robyn, can you tell everyone why you don't ever need a mammogram again?
Or a bra.
Or a bra. And I'm so proud of you.
No bra. No.
I'm so proud of you for that too, for spreading the word about this, because it's another.
When I explanted, I chose to stay flat, and at that point I was so done with boobs in general. I just wanted to be done. But also, I'm very comfortable being flat. It's easier to exercise. It's easier to be physically active. So, and it was one of the options that was not presented to me. And I will say that our flat community has grown so much in the last 5 years. When I had breast cancer, when I had breast cancer in 2017, I don't think anyone was even really talking about it. If they were, I wasn't able to find them. Kimberly Bowles is a huge flat advocate that has done amazing work in getting language changed. Also, Andrea and I we were able to meet with NCCN and get the NCCN guidelines, the clinical guidelines changed for breast cancer patients. So if a surgeon has a patient and they're diagnosed with breast cancer, the NCCN clinical guidelines now state when you're giving their surgical options to include aesthetic flat closure.
Wonderful.
That was a huge win for us. And just the community and the way it's grown, and just the beautiful women that are out there that are just really sharing their stories and empowering other women to do the same. I'm really proud of our whole flat community and the movement that they've started, because it's not for everyone. Reconstruction isn't for everyone. It's about choices, and it's about informed consent.
Exactly.
And when women didn't even know that they had this choice, it's surprising that I think there's a stigma attached that most women want breasts, and it's not true. I mean, almost half of all breast cancer patients now are choosing to just stay flat. They're seeing the horrors of reconstruction surgery. They don't want to have 12 surgeries or 22 surgeries. And, honestly, as we're talking about malpractice and just being ethical and moral, what plastic surgeon is okay with continuing to perform 27 surgeries on a breast cancer patient? At what point do ethics kick in and say, honey, this might not be working out for you?
Right.
It's really a shame to see that, and at some point the woman has to decide what's best for her health, what's going to be best for her body. Aesthetically, I don't even know how after that many surgeries, the results can come out pleasing at that point. So it is really sad for me to see that in the breast cancer community. But again, it's about choices. It's about informed consent. And I'm just really proud of all the women out there that are sharing their story and just getting the word out there. I think it's great to see, and it's empowering other women.
I don't think people realize the massive amounts of support pages that are now flowing on Facebook and Instagram. Well, Facebook, I don't know about Instagram. I don't know how to work Instagram, but Facebook, there's numerous support pages. And so there's one for everyone. If you don't think you fit in one, or you're not getting information you need in one. And there's one called the itty bitties, like, because you remove, like, I'm totally very small. I mean, mine are, so, you know, you have to put yourself in the mind of women. There's a reason why I had a complex, you know, and went and got breast implants. And then you end up with these beautiful breasts, and then they made you sick, and now you're back to flat again. You're right back to the mental state where you went and got them. And it's a lot for women to handle.
No, that is true. Now, this is very important, because if you look at the ladies as they get older, they realize it absolutely was not worth it. Sometimes, and a good number of times, as you will see, the ladies never wanted it. It was the significant other who was the driving force, unfortunately, who was funding and financing the whole surgery itself. And I find, you know, this is a very serious matter. Now, if I tell someone, and again, if you get implants, you could get cancer, they last only 10 to 15 years. So if it's a young lady who's in her 20s, is she going to get replacement 6 times in her lifetime,
Right.
let alone all the problems,
Yeah, they're not
contraction,
told that.
infection, asymmetry, right? And then the breast implant illness symptoms. Remember the need for MRI for silent rupture, according to the manufacturers themselves.
Can I ask you a quick question about MRIs?
Yes.
Are there dangers getting MRIs all the time too? Is there radiation? I mean, are there any risks to MRIs? Because if these women are having to have them so often, that's a concern.
No, good question. So the MRI that is done to look for a silent rupture for silicone implants, there is MRI stands for magnetic resonance imaging. So there is no radiation, and there is no contrast. So it doesn't hurt the kidneys. No contrast hurts the kidneys. And so you're just like in a radiation, in a magnetic resonance imaging chamber, which is the MRI machine. There is no radiation, zero radiation. And so you could get a newborn into an MRI machine and it won't hurt. You know, you may have to sedate the baby, obviously, but in this case, it's a 1 hour or so to get the, now in those patients that need to get an MRI to look for breast cancer, then you have to put IV contrast. But if a lady has silicone implants and you want to rule out rupture, that's MRI without contrast to look for a rupture. And that is very benign, safe.
Can an ultrasound pick up a rupture?
Ultrasound is technical dependent, technician dependent, and it is sound waves. And sometimes if we have a very thick wall of the capsule, the sound waves may not be able to penetrate. So it is better than nothing. And it's a very crude test, just like a mammogram. Mammogram, remember, looks for calcifications. You have a screening mammogram, then you have a diagnostic, then you have a 3D, you have different types. So the mammogram is looking just for breast cancer. The ultrasound is looking maybe for a cyst to better define, maybe looking for like a quick, crude, non-invasive by the bedside check, which can easily miss what may be a rupture. Now, even the MRI, which is the best test that's out there, can sometimes even miss a rupture. One day I did a case where there was 2 back-to-back patients, both had MRIs. The MRI on the first patient said it's ruptured, and lo and behold, it was not. On the second patient, it said it was not ruptured, and the implant was ruptured. So what a coincidence.
Yeah.
I have a problem with mammograms with implants in, and I have no explanation of why I got a rupture after 12 years. I had saline, so I woke up and it was just flat one day, which then that all traveled through my body. All that could have been moldy, or you don't know. But I had no explanation what caused that. And I often wondered if it was sticking my breast implant into a vice grip every year and having them smash it when it keeps continuing to deteriorate over time. So it's breaking down and dissolving. You've seen it a million times, Dr. Khan. So then we're sticking them into a mammogram machine, and then you bust that capsule open possibly. And then there goes all the issues flying out into these women's chest walls. And I have a hard time with mammograms when it comes to breast implants. I don't think we should be doing them. What are your thoughts on that?
So number one, we heard Robyn, a mammogram literally
with implants in.
No, yeah. So
I'm okay with them without implants. It's with implants in. Why are we sticking them in a vice grip?
Right. So a patient who gets saline or silicone implants on any given day is traumatized with pressures be it a car swinging open on a windy day, riding a bike, another person hitting, or just basically being on a roller coaster and being bounced around. Plus, there's so many, like a kid, for example. I had a patient that came to me and she said, my 4-year-old child ran towards me and kneed me on my left breast. And ever since then, I've been hurting and I can tell it's ruptured. And believe it or not, she was absolutely right. It was indeed ruptured. Now, she said clearly, everything was fine till my 4-year-old son came and he literally kneed me right in the chest. And it was the most painful thing that she had felt. And she said, my breast was never the same. Now, I'll tell you, I believe her story that this was a direct result. Now, every day we put ourselves, even us, our hands through so much trauma, right? Now, yes, when you go and check and get a mammogram, now fact, millions of patients all over the world have had mammograms with saline and silicone implants and they were not ruptured, correct? Now, there are many, now this is a fact, every single day all over the world. In
But
Europe,
did they
in South
rupture
America.
like 6 months later? That's, did
See,
it
so
cause,
there is
did
no,
it
correlation.
contribute?
So there is no correlation. There is no correlation between getting a mammogram and getting a rupture, but there is a correlation between not getting a mammogram and getting breast cancer being picked up late. So that risk is there. Now, hopefully you get rid of the implant so you don't even have to worry about, because remember, there are so many patients, their mammograms are red, and the mammogram report says, because of the technical deficiency of getting the mammogram, because the technician felt uncomfortable or the patient didn't want to, they got an incomplete or a substandard study that has missed, cancer. And sometimes the implant is so large or grade 4 contracture that they truly are not able to do a mammogram on the breast tissue that they're able to see. So that is a compromised mammogram. So there are so many mammograms that are done that are not effective simply because of the fact that the implant is getting in the way. Now, there have been studies that have been done that show, well, these same ladies, they have breast cancer that's picked up more because these are the patients, they may have insurance versus the other patients who do not, for example. Now, at the end of the day, you have a distortion of the chest. To answer your question, mammograms are absolutely mandatory. There are millions of patients who have had mammograms with implants safely, and there is no direct correlation between patients getting mammograms and a direct rupture that same day or even 3 months later. There is nothing on literature. I dare you to find anything, or myself, I have not read anything that states that there is a correlation or a study that has been done. Now,
Okay.
if a patient says, well, I don't want it, again, talk to your doctor, go to the breast center, and at least get an MRI, because you don't want to miss breast cancer.
Right.
You mentioned capsular contracture. Can you explain? Because we sit there and tell, oh, you got to remove the capsule. We've been saying this whole time, you have to remove all the tissue, all the capsule. Can you explain what a contracture is?
Yes. So let's talk about a capsule. Anytime you have any foreign body in the human, be it a pacemaker in the chest for cardiology reasons, be it a lap port for lap gastric bypass, or a hip, or in this case, a breast implant, be it saline or silicone, the body in itself mounts a response or a scar tissue, in this case, a capsule around. It identifies it to be foreign. Now, with the pacemaker, it's stainless steel or titanium. It's inert, meaning it's metal, right? Or I have 5 screws here in my little finger, titanium from a car accident. It's non-reactive. The body itself, it's hard. It's not leaching copper or zinc or whatever it may be, titanium, because this is why they chose this hard substance. I wish they make implants out of titanium, because then they won't be reactive. But the point here is that now the capsule forms. Now, remember what we talked about earlier, the implant, saline, and also silicone. And especially when the silicone is ruptured, it's leaching out silicone particles. The body itself then forms and tries to entrap. Now, sometimes they can get calcified. Sometimes the capsule forms thick boundaries and kind of grow strongly in order to protect. Sometimes it may be a very thin capsule. Now, each one of these capsules doesn't signify if this is worse disease or bad disease. Sometimes liquid, i.e. A fluid forms around. Now that raises a red flag for lymphoma. Now, going back to your question, that capsule is the body's response to a foreign body. In this case, the silicone implant. Now that harbors in it the silicone particles. We know this because look at the pathology reports. So it is imperative to remove that capsule because in it are the silicone toxicities, the impurities that continue to hurt the body despite removal of the implant. So this patient today that came, she had residual capsules, and we know from a whole series of patients who have had implants removed and capsules left behind that they continue to hurt till the patient goes to another plastic surgeon who removes the capsule sincerely, definitively, and now the patient bounces back. So these capsules must be removed. Now, the capsular contracture, you have basically 4 different grades, where the highest grade is where you have thickening and distortion of the chest wall as a result of the implant being suffocated, tightly compressing the implant, and the patient has pain.
And you'll see a lot of, you can tell, you can always see it in a woman.
Right, irregular, yeah, exactly. So this may be riding up high or to the side, and it is so tight. And you can go to my Facebook page or any of the YouTube videos, and you can see the example where it is so tight, suffocating, compressing the implant. Yes. And there is pain because that might be in the proximity of a nerve. So that's grade 4. Grade 3, you have this hardness, this irregularity that you're mentioning, but no pain because it is in a soft area. And then grade 2, where you have palpation and the distortion is really not there.
Okay.
And grade 1 is where you have normal symmetry and normal exam essentially of the chest. And you can Google this capsular contracture, what they call Baker's classification, grade 1, 2, 3, 4. And you can see these highlights and pictures. You can also go to my page, I define it, or go on YouTube, Google Images, and you can see that as well.
And Dr. Khan, do you have time to take questions?
Yes, yes, absolutely.
I don't know what your
Please go
time,
right ahead. Yes.
I don't know what kind of time you have. I know, Robyn, you might have to scoot, but can you tell us really quick, you started GPAC, and I wanted you to tell everybody what GPAC was before you go. And then we'll take questions for Dr. Khan after you go, because I think you have to scoot, right?
I do in a little bit. I've got it out.
So whenever you got to go, you just go. But I wanted to find out about GPAC. Tell everybody about GPAC first.
Yeah, so Terry Diaz, I actually met her at the first FDA meeting that I testified at. She runs the Florida Breast Implant Illness Support Group, and together we started GPAC, which is the Global Patient Advocacy Coalition. And we work with anybody. We work with surgeons, we work with other medical professionals, we work with societies, the FDA, TGA, Health Canada, BFARM, you name it. We'll talk to anybody about this, and just our goal is to raise awareness about breast implant safety and also proper informed consent, and just to overall improve the standard of care and just make sure that patients are being protected and informed, and that the medical community is aware of these things that are going on. So that's kind of what we're all about. And it's been great to work on legislation. It's been great to work on the patient checklist. And it's just been an honor to work with so many great people and just meet so many people that we would never have met otherwise. So it's an honor to be here.
I think you're doing great work. Okay.
Now let me ask you this, Robyn, because it's very nice that you are, along with Tracy, what would be the leaders that will translate what the patient's voice to the FDA. Now let me ask you this: what is it going to take, from your experience, Tracy and Robyn, you can both answer, for the FDA to step up and say, you know what, we're going to take the leadership role, Dr. Bashar, for example, and say, you know what, implants are bad, and we're going to take that executive decision where we're going to take the implants off the market, hopefully both saline this time and silicone, and say we're going to ban the implants altogether. What is it going to take for the FDA to do this?
They're ready to launch another brand. They're not stopping. They have no intentions of banning them.
No, I don't think it's going to happen, honestly. And it's really unfortunate. And and I'm not trying to make light of the situation, but you know, romaine lettuce is notoriously pulled from the shelves because 39 people got diarrhea, you know, but we have literally women being diagnosed with cancer and dying from ALCL, from squamous cell carcinoma, from other T cell, B cell lymphomas, you know,
Suicide.
but yeah, we've actually had several in our community that have completed suicide, but it's sad because there's a lot of money at stake.
Yeah.
A lot of money for
A lot of legal kickbacks too.
a lot of manufacturer money going on. And, you know, a lot of if you look at some of the society leaders, they've taken hundreds of thousands of dollars from the implant manufacturers. The FDA itself gets the majority of its funding from user fees from the medical device manufacturers. So, you know, it's round and round we go, right? It's just the system, honestly, that's broken. It's the approval process is broken. The 510K process, which is a loophole that medical devices use to get their products on the market, if they're even remotely like any other product out there, even if those products have been banned or recalled, you can still get a medical device approved. So, you know, the reporting of adverse events, you know, luckily the FDA stopped allowing alternative summary reporting. But when Tracy and I went to the FDA in 2019, it was discovered that very week that the FDA was hiding over 446,000 reports of women harmed by breast implants.
Wow. So this is very alarming. You know, like how can you hide or how can you justify this? Then what's the point of reporting? Then what's the point of reporting?
In our meeting last week, you know, we had made it very clear in our meeting prior to that the FDA thought the words they used were that they had broadly communicated breast implant information. And then, you know, we crunched some numbers. We found out how many medical professionals are in the United States. We found out how many, what target audience their announcements reached. And we showed them that they were not doing a good enough job getting this information out there. But they made it very clear the information's not coming. It was even suggested that us patient advocates put the information out there to the medical community, which of course I'm trying, but I don't have access to 5 million medical providers, nurses, doctors, societies. And I told them that. I said, you know, we don't have the tools in our toolbox to be able to have that kind of reach of that broad of an audience of medical professionals. So it really is unfortunate. And, you know, I have been having meetings for about the last 4 years with the FDA and feel like we've been heard and you know, that the patient perspective has been respected. But that was truly, there's no reason I can think of whatsoever why they would not put that information out to help patients. I mean, they're literally delaying care, proper and timely care of patients. They are literally delaying cancer diagnosis, timely cancer diagnosis that can be life-saving if caught early.
Well, they tell women, oh, if you have the textured implants, don't worry until you see symptoms. Don't remove them now as a precaution. Wait till you get sick. How does that make sense?
Yeah, that does. And it goes back to Dr. Khan's point earlier. At some point, we have to think of common sense. Look, I get it. I mean, there are millions of women that have those Allergan BioCell texture devices in their bodies. And you know what? It would be mass mayhem, wouldn't it, if they all decided to run to explant because they were worried about developing cancer. But, you know, we should have been more cautious. The medical community should have been more cautious when they were running around the country and the world promoting those Allergan implants as the gold standard, the new textured Allergan devices. I mean, the leaders of one of the societies were the clinical investigators on those implants. They told us those implants were safe and effective. They told us those implants were the gold standard. And now they're recalled worldwide for causing cancer. A lot of those same people are on the clinical trials for Motiva, the new breast implant that's coming to the market with the microchip in it. So, and those are the same people that are telling us, don't remove the capsules, it's not necessary.
Yep.
At some point, we all need to pause and think of common sense. And does that make sense? Does that make sense that we know now some of these cases of the Allergan texture devices they have a chance, now 1 in like 387 chance of getting ALCL lymphoma. You know, we have to pause and think about that. And then their recommendation to leave those in the body until you show signs of cancer is just ridiculous.
Oh,
It's
another concern is them using mesh in the breasts.
Mhm.
It's a whole
People
Sure,
nother.
in
react to
cancer
mesh
patients-
exactly like breast
Sure.
implants, and they're putting them in their breasts now.
Now, what have you seen in regards to the insurance companies, Medicare, taking, basically footing the bill for an explant if the patients, for example, develop contracture or signs, symptoms of fluid collection or pain, BII symptoms, for example? What is it going to take for the insurance companies and the government, the Department of Health, to mandate what is an ICD-10 code for breast implant illness, such that the insurances will ultimately cover this explant surgery?
You know, that's a really difficult question. We actually submitted proposals for an ICD-10 code, and same group of people that thought it wasn't a good idea. So it's unfortunate that the patient safety aspect is not being taken seriously, because if there was an ICD-10 code, you know, we would have more women that were able to get insurance coverage for this. But it's really highly stated that these are elective devices. Now, breast cancer is different. Breast cancer, you know, due to the Women's Health and Cancer Rights Act of 1998, breast cancer reconstruction and explant are all covered by insurance. I will say this, since I've been doing this in 2017, I am seeing more insurance companies that will help cover explant due to pain, capsular contracture, like you said, a seroma, especially now with these cancer announcements. So we are seeing insurance companies cover that more and more. Unfortunately, most plastic surgeons enjoy a cash pay business. So they typically don't deal with insurance companies. Their office staff doesn't even know how to deal with insurance companies because most of their patients are cash pay.
Right.
So,
Now, I will mention, Robyn, as a plastic surgeon, having dealt with insurance. Now, I want to take this. The number one reason for bankruptcy in the United States is not foreclosures. It's not student loans. It's the medical bills, by far. Number one fact, medical bills are the number one reason for bankruptcy. The entire health industry in the United States is in turmoil. Nowadays, the surgeon does not get reimbursed. So if I were to reimburse and say, for example, submit the claim to the insurance, if I do get paid, that's number one, if, because they say, if I go get a facelift and it goes bad and you get an infection, and I go to the emergency, like, who told you to get a facelift? So everything that comes from that complication is yours. And this is what they majority of the time say. Now, let's say they're being generous enough and it overlooks the committee. Remember, they don't even look or open or read, and believe it or not, they automatically deny coverage without even opening the file.
yeah.
So vast majority of it, now I know this because it goes through, I see these patients, right? And there are patients that get reimbursed. Sometimes they get reimbursed and then 6 months later, hey, by the way, we paid you in error, give us the money back, believe it or not. So I've seen that happen too. Now, in those cases where, let's say, they do cover, they say, who told you to remove the capsule? That was not required. So just removal of the implant, $250, $550, $750, $1,200 on average. That's it. That's all with the cover. So I just want to go ahead and make it absolutely clear. If a patient says, oh, I found this nice surgeon, he believes in BII and he's going to take my insurance to do an explant, I will tell you 100%, not 99, 100%, that surgeon is going to do an incomplete job, be done with the surgery in 20, 30 minutes, remove the capsule, maybe rupture the saline implant or just pull it out, leave the capsule behind, or maybe partially remove the capsule. And he or she will not spend more than an hour removing the implant. And I'll tell you, as a board certified plastic surgeon who 99% of my practice is exclusively explantation, it takes me 4 hours to do an explant. And I will tell you 2/3 of the time I'm running over the 4 hours. And this is a surgery where it's not about the time. It's about whatever length of time it takes. So any plastic surgeon, be it at the university setting or a private cosmetic setting, who says, I take insurance and you don't have to pay a dime or even a co-amount, that surgeon 100% will do an incomplete, bad job, i.e. he is not fixated into removing the whole capsule. And now the patient, if he asks me, will only potentially be hurt, because now let's say if it's a ruptured silicone, or if they ruptured the saline in order to pull the implant out, which they do all the time, then that patient now has to deal with what may be a ruptured silicone within the chest or residual capsule, which is relatively harder to remove, like today's case. And now the patient has to suffer and now undergo another surgery unnecessarily. Now, this is not like maybe, this is 100%. So you get one shot at this. Do it right, do it definitively, do it completely. And I will tell you, if any person, i.e. plastic surgeon, who takes insurance, that's a recipe for chapter 11.
I have seen some surgeons that are taking insurance, and I've seen the patient will share in the Facebook groups pictures of the capsules and they're feeling better. And a lot of the patients, I think what they end up doing is filing on their own after, like they'll pay the plastic surgeon for the surgery, and then afterwards they'll
right, which is what I do. Yep.
Yeah. And I've seen women get it covered. I help women out. People call me all the time and ask how to do it and what codes are used. So,
by all means submit, but for the surgeon to say, I'm going to take only your insurance and you don't have to pay me, that a surgeon will not, because you cannot justify a 4-hour surgery and only get compensated $800, $1,200, because just to open an operating room and a board certified facility where everything is done up to the standard. Remember, at my operating room, I have a certified first assist, a certified surgical tech, a certified facility itself. Just to maintain it, just to open up a room is $800.
Yeah.
How can you justify it? Plus you have to pay your fee, you have to pay all the costs of running a practice, which nowadays has absolutely increased compared to 2 years ago. Everything is going up. And the point I'm trying to make here is, even let's say, for example, a colonoscopy, right? Do you know how much in the state of Michigan, this is at least 2 years ago, how much does a gastroenterologist get paid for a routine screening colonoscopy, no polyps? $205.76.
Wow.
How much a gallbladder? How can you, even let's say if I did 10 of these, right? For example, colonoscopy, you cannot justify having a full practice. Even if you have an assistant or a fellow, you cannot justify in today's, if you go to a family medicine doctor, look at the explanation of benefits. You're going to find they sometimes get paid $35, $62, $89, not more than that. And now, unfortunately, the entire hospital system, and I'll use this platform, is a money-making enterprise at the expense of the patient, at the expense of the doctor. The hospitals are big mafia institutions. You walk in an emergency room, just from the time you sign in, you go in, you get a $2,500 bill, just basic routine. And they will overcharge, double charge. I know friends of mine who work in the emergency room, they were told, give an incentives parameter so we can charge $25 because we buy one for $2 and we can charge, or the Tylenol pill or an x-ray or an EKG.
Or the $52 box of Kleenex.
Yeah, exactly.
And while we're talking about medical, and I do have to run, I have to jump off in a couple of minutes, but when Allergan issued their voluntary recall, and I think they wrote a statement or put out some kind of statement saying, if a patient does get diagnosed with BIA ALCL, they receive $7,500. And that is a joke. That is such a slap in the face to cancer patients, because anybody who's been diagnosed with any kind of cancer knows that just alone biopsies, imaging, labs, that's the bare minimum of a cancer diagnosis. And then you get into surgeries and any other ancillary things that come with it, treatment, chemotherapy, radiation. You're talking hundreds of thousands of dollars. And you yourself brought up the point, most people file bankruptcy due to medical bills. for Allergan to offer $7,500 that's just abhorrent. And it's sickening to
Yeah,
see
you
how
know,
far
if you know, Robyn, you're in this as well every day. You talk to the patients. Let me tell you this. I had a patient, she had insurance. She was hand to mouth. And I said, you know what, I will do you at the hospital. The day before, this is typical, by the way. We get a call from the insurance carrier that we're canceling because this is not essential surgery. This is for a cosmetic. I then call, and then they said you can go ahead and ask for a peer-to-peer review. So I requested for that. When I talked to the doctor, and I said, do you mind? After like a minute, I was like, do you really know what you're doing? So I asked him, what is your expertise? What do you do? He said, I'm a pediatrician.
Oh my
So
gosh.
and I will say this, they hooked me up with a pediatrician to make the call if this patient should get an explant or not. Now, I'm not making this up. I actually mentioned this doctor's name. He's in Florida. And I asked him, are you even practicing? You know, sometimes, you know, you may get like an illness or you cannot practice, but you can give medical advice, or, you know, the insurance companies love you because you're paid to say no. Just and then let me give you another story. So this is the world that we live in, unfortunately. It's all sad. Now, the pediatrician told me, can you send me literature on BII and why you need to take the capsule? I said, this is not my burden. This is your burden. And I said, I'm going to record this conversation just like you're recording mine. And I'm going to play this tonight on my Facebook Live because I was doing one that day. And he said, you cannot do that. And he literally hung up. There was another surgeon out of Beverly Hills, California, about a patient of mine who took a FMLA 8 weeks. So they denied coverage for the FMLA. They said you should be back at work in 2 weeks. Now the insurance company had hired this plastic surgeon to speak on their behalf. Now this surgeon is putting in implants, board certified. Now when I called the surgeon, and I'm very good, I said, this is my responsibility. The patient is, I'm not charging the patient anything. I said, I'm going to speak on behalf of the patient. So I called the plastic surgeon and I said, why is it that you're denying? The implant was 450 cc's below the muscle. The pectoralis has to settle. It takes 6 weeks or so of recovery time, and you're just allowing 2 weeks. Then I talked to this doc and I said, who are you? What's your specialty? What's your training? And he was an internist. I said, you've never even stepped foot. The last time you were in the operating room was when you were a medical student. And how are you making a decision on behalf of this surgeon? You know, in Beverly Hills, this is Dr. Feroz, to name him. Now, I said, shame on him that he gets paid to say no because the insurance companies love him, because now there's no check and balance on him. And unfortunately, you have a series, this is all about money, and that is unfortunately the reality of it. So now going back to the point here is, any surgeon who will spend 4 hours, 5 hours, whatever length of time, certainly more than the 3 hours, and get compensated $600-800, you cannot justify the intensity of the surgery and the time and the commitment, plus the expertise. You know, how many patients have asked me, why don't you get like a co-surgeon or another person who can? I said, I don't trust the other surgeon into removing the whole capsule, because within their heart, they would not want to remove it.
Right. I do want to, before I jump off, I do want to thank you and all the other explant surgeons that are taking really good care of our patients, that are committed to removing implants properly, no matter how long it takes. I know that it was really hard for all of you to kind of step out there and put your neck on the line and speak out about this. Just since I've been doing this for the last 5 years, I've seen some of the bully tactics that have gone on with you know, your peers and your colleagues, but nevertheless, we still have a really great group of explant surgeons who are continued to being committed to taking care of our patients. And I want you to know how immensely appreciated that is in our community. Because when Tracy and I still every week, I had a woman come to me, I had 3 women reach out to me just today, but every week we get women that come, and when they find out about all of this, they're frantic. And their first question is, how do I find a good doctor? And for those of us who watch and pay attention and put our time into this community and our effort to get to know the doctors that are doing it the right way, we just want you to know we appreciate it. And, you know, we're just happy that we feel comfortable in a place where our women have options. Our patients have options to make an educated choice. So thank you for that. Thank you for your time tonight and just all the time you spend with our patients, because I know in that 3 or 4 hours that it takes for you to remove implants and capsules, I know that down the street, there's a surgeon right in your town who's popping in 10 sets of implants.
Yeah.
And a heck of a lot more money.
Within the time, it would be at least 3 or 4 implants that you would put in. So it's 4 times. Now, I will say this, Robyn, you know, I appreciate your, you know, nice words and your kind words. I will tell you, I, as a human, as a physician, as humanity, right? This is the right thing. This is a no-brainer, right? This is just like you would. Would you ever hurt or cause harm to someone and financially benefit off of someone else's misery? Because this is essentially, especially given the mountain of evidence we have, right? This is no like, we're like in the 60s or 70s. We're reliving whatever the same set of problems in the 90s. And I will say this, it's sometimes I find, you know, the root cause of evil is money. And I will tell you, what goes around comes around. You know, I believe in karma. And I'll tell you, yes, I would be 3 times, 4 times richer financially, but I will tell you the contentment, the happiness, the peace that I have into going about and just speaking my mind. Today, I spoke my mind. I have no ill will against anyone except for the benefit of my patients. There is nothing, if anything, you know, this is where, if you just look at the facts alone, if you look at what we did, we talked about facts, it is no denying that there is, the implants only hurt the body. They do not belong in the patient's body, and they need to be taken out before they cause more harm. And that is the whole essence of explant surgery as well.
Yeah. Thank you so much. We appreciate you. And I'm going to pop on tomorrow and check out the questions to see, because I'm dying to know what questions we have tonight. So thank you everyone for allowing me to join. And thank you, Tracy, for having me on. I appreciate it.
Thank you for.
Bye-bye. Thanks, Robyn. Bye-bye.
All right.
Bye-bye.
Have a good night.
Keep
Love
up the great
you.
work. Thanks. Bye-bye.
All right, Dr. Khan, we have Evelyn, who says she was 15 minutes away from electroshock therapy treatment. She was so depressed. I actually sat there thinking, I was Googling electroshock therapy. I was so severely suicidal. I was Googling electroshock therapy just like her. Glad I didn't do it. My friend.
No, I want to say this to the patients, and I want to say this to the significant others. Implants take a toll physically on the chest, but if you ask the mental toll of depression, anxiety, emotional instability, abrupt anger, suicidal ideations, this is a very real problem. You know, the psychologists and the psychiatrists need to understand this is an integral part of what is breast implant illness.
I had contacted that Dr. Amen or Amen, I don't know how you say his name, A-M-E-N, and it was $7,000, I think, to get a brain scan, but I was convinced like there was fluid or something from the inflammation up, you know, causing this suicidal depression, and I just couldn't pay. We have to pay out of pocket for our surgery. So there was no way I could afford a brain scan, but we need a doctor, a brain doctor, like, you know, whoever does the scans, those kind of doctors, we need one that will team up with us so we can prove something is seriously happening with women mentally when they have these breast implants in. Not everybody, but when you do react and it comes down on you, it was the darkest abyss I have ever been in my life. And now I'm perfectly fine. So where did it go? You know, I mean, I always had PMS my whole life, but this was beyond. This was beyond. I didn't even want to live. It was so bad. And then the next day you could be perfectly fine. So I think I would love to get down to the root cause of what's causing the, but let's see if I'll try to find another answer or question for you. Oops, and it just jumped. So hang on. Why isn't the FDA letting all the doctors know about breast implant illness? Why won't they send the letter to all specialties? It would save women from going to doctor with no answers. I have 33-year-old Dow Corning implants. The doctor never said a word about the implants already being considered dangerous. A year later, they were taken off the market and class action was won. The surgeon assured me I had no problems and never had to touch them. Yeah, that's very common. I hope people see this, women see this, husbands love their wives. I had a surgeon tell me the capsules don't need to be removed. A lot of surgeons will tell women that they're intentionally leaving the capsules behind because you'll have a better shape to your breasts post-op, and it's a big lie. I mean, you might have a better looking shape, but you're gonna be very sick possibly. It's clear indication that a surgeon doesn't believe the women when they keep operating and implanting. Okay, I'm not a question yet, but we'll get there. Implant tissue and inflamed tissue must be removed. Dr. Khan, do you do consultation from a distance, or do we have to absolutely be seen in your office? I'm in Montreal, Quebec, Canada, but I don't trust the surgeons I've seen. Well, I'd have to say, since you're doing people from all around the globe now, because you've done several from around the world, that you must be video conferencing with them first, possibly?
Yes, so I do a phone consultation, and then if I need more information, I do request that. But phone consultation is a very good, healthy way to start. I'm able to get a lot of information. Sometimes I do ask for the pictures so that I can see what may be a double bubble deformity or problem, for example, that may be present. So this is where, I'm so blessed to say that I've had patients that I've taken care of from Qatar, from Saudi Arabia, from Japan, Germany. Like today's patient was from the Netherlands, from Panama, from Egypt, and again, all the states of the US. And they come to me, they buy their day without even talking to me, without even the phone consultation. And I'm so blessed and lucky that, I have this bond with my patients, and I'll tell you that means the world to me. And I tell each and every single patient that I do this 100% from my heart. There is no other thing in my mind other than to help the patient. From a financial perspective, I was very happy even before, if you ask me, I started medicine. And so that was never an issue. That is not an issue, and there will never be an issue. I could have retired a long time ago and be very happy. And again, the finances certainly are important because this is what's driving. I have a friend of mine who's the nicest guy who goes to missions to Nepal, for example, and other parts of the Honduras. But when I asked him, why are you putting in implants? And he said, well, someone has to do it. And that is not a good enough of an answer. Implants only hurt the body, as we talked about so many points. It is not worth it, and you should do no harm. Do not harm the patient. That is the ultimate goal of a plastic surgeon.
Does your pathologist look for silicone?
Yes, so that's a very good point. Now remember, silicone sometimes are crystals. So if you look at the pathology report that I posted on Monday and Tuesday this week, you will see the pathologist clearly mentioned breast implant particles. Now, sometimes the particles cannot be seen, or these bifringent crystals, for example, so they may not be picked up, because remember, they're looking for cancer. Breast cancer, squamous cell, abnormal cells, histiocytic cells, giant cell reaction. Now, in order to look for silica, which is dust, sand, right? You have to have electron microscopy, which is looking for silicon, or energy dispersive x-rays. So you have different tools, not a microscope, not stains. So that is a different lab. So for example, Dr. Atul Mehta out of the Cleveland Clinic, he did a lung biopsy on a patient with intact saline implants. Or Dr. Henry Dykman, who did a cadaveric study of a patient who had a rupture of silicone implant. Both of these biopsy samples were sent to a special lab where they did electron microscopy and energy dispersive x-rays to look for these particles. So this one patient who had saline implants that I removed intact, I sent the implants via FedEx to the Netherlands to Dr. Henry Dijkman, who took the saline out and then centrifuged the saline out of the saline implant and collected what was a pellet. And he showed under electron microscopy that there was silicon within the pellet itself, consistent with silicon that was leaching from an intact saline implant. And
Wow.
this is, if it's going into the saline, it's going into the rest of the body. And this is where I was mentioning the UCLA scientists are looking for a lab test to look for silicon. I will tell you, you don't need to do a test because there is gel bleed that's occurring from day one. And even if the small amount of silicon is picked up, the goal is to remove all of this, the entire capsule plus the implant, be it saline or silicone, such that none of this leaches into the body.
Right. Is it true using infrared light treatment is dangerous when you have implants?
So I will tell you, people go through all sorts of lights. This infrared light has not been shown to be dangerous. From what I understand, this is, remember, there is no correlation in any medical literature that proves that this light hurts or ruptures or causes damage to the implants.
Okay. So many surgeons and or MRI facilities are demanding contrast dye for checking for rupture only. Unacceptable.
That is correct. So if you want to look for a rupture on a silicone implant, you have to do an MRI without contrast. To doing it with contrast, you're looking for cancer, for malignancy.
My breast implants have been leaking, disintegrating for over 3 years now, and I'm still on a waiting list for my explant at the hospital. I'm allergic to anesthesia. Oh my gosh. And I already have a collapsed lung. So many surgeons in private clinics that I have consulted don't want to touch me due to this. Can you handle her?
So when you have a collapsed lung, we need to know why, right? That is not healthy. Now, you certainly, if you have a collapsed lung, you have another lung. I operated on a patient who actually had a pneumonectomy, which means one lung was completely gone. And she was living off, a young lady in her 30s, late 30s, young mom that came to me from the Dominican. She was just living off of one lung. People can do that, but we need to know why, what are these allergies, and you absolutely need to be done at the hospital, and they need to do a complete reason. Just this week, I took care of, last week, on Monday, I saw my patient post-op day number 4. At age 27, she had what was a respiratory arrest in the recovery area back when she was 27, 14 years ago. Now, this was a complication of a young, you hear about this, right? Maybe that was not a certified facility. This was a patient, Dr. Razvi, her primary care doctor, cleared her and okayed for her to come to me. And I looked at, my anesthesia team looked at, and for the last 14 years, she had no cardiac issues and she was in her late 30s. Now, the point here is that she met criteria to get the surgery done safely in my surgery center, which is an outpatient facility. Now, the last few patients that I did, she had 2 stents in her heart and an open heart surgery. That's the one I did on a Monday at the hospital. Another lady I did almost 7 weeks ago. She was on 5 liters of oxygen. And there are many patients that I've done at the hospital who meet criteria to be done safely at the hospital. Another 42-year-old, she had metastases to her neck from breast cancer. And she indeed had a ruptured implant. A young mom, and I was reluctant to do her at all. But because of her exam, and because of the pain she was having, I said, we have to take the risk versus benefits.
Wow. Wow.
And she has to be done. So this lady, she has to go and she has to be done at the hospital, and a surgeon who's going to remove all of the capsule and not compromise her recovery by saying, well, she's so sick, I'm just going to go in and out and remove. Look at that one patient that you and I were involved with. She was in the ICU here at a major hospital in Detroit area.
Oh,
and
yeah.
her surgeon, board certified, chose to do it by the bedside, if I'm not mistaken, or a quick run. And
He was gonna, yep, they were gonna.
Yeah, in the ICU, but they ended up going to the operating room, quick in and out. And then they used what is an argon beam, right? Which is unheard of. I've never heard this, where they could blasted the capsule with a special heat, which they use for the liver. And I've never heard that before, which again, the point here is it needs to be done right.
Right. Yeah. Gail says if this issue affected men's testicles, you could be darn sure the information would get out and the implant would become illegal. Well, actually, Gail, men are getting them, and they're also putting them in dogs, and the dogs unfortunately can't tell their owners that they are sick from them, but it's coming. Just give them time to react to them.
One thing I want to do is, look, Tracy, with Robyn, you and I talking, all the ladies, get your cell phones out and just gently, humbly, professionally talk about your right to the FDA. We heard from Robyn over 400,000 complaints. At least that's written, right? Now, document right. Now, this is where, what are we seeing today? The FDA is not doing much. It's very passive, being politically correct. The plastic surgeons are not talking much. The general practitioners, family medicine, rheumatology, allergy, none of them are truly talking because they're saying it's safe. The manufacturers certainly are not doing anything about it. And the patients are now talking to the other patients. And this is basically what's raising the awareness, where now this is no longer the #1 procedure. And what I want each one of you to do is reach your other fellow sister and let them know that this is what is breast implant illness. It is very much real, and that they, with an open mind, non-biased, make a decision for themselves with no outside forces, no significant others calling the shots. And then you take ownership of your own health in your own hand and very assertively and politely reach a decision that benefits you, because you are the victim and you're the beneficiary of the removal of the implant in a very certain definitive way.
I had my explant and only had 75% of the capsule removed. Should I have the other 25% removed?
I'm sorry, can you say that again, Tracy?
I had my explant and only had 75% of the capsule removed. Should I have the other 25% removed?
So good question. I will tell you this. I have read so many operative notes from these surgeons who stated I removed almost all. I go back in, 90% of the capsule remains behind. So this 75-25, I question if this is even real. Number two, remember, if she has, number one, go to the doc, make sure your thyroid is good, all those other tests are good, you don't have lupus, rheumatoid, whatnot else, all these other organic causes of problems ruled out. Number two, how much are you affected by what is breast implant illness or the residual capsule problem? How many signs, symptoms do you have on that checklist, from fatigue, brain fog? Look at the lady that came today from the Netherlands that I operated on. She is 29. She cannot function. She has a full job, but now she cannot get out of bed, brain fog, fatigue, joint pain. She said, I cannot live like this. I have to do something. I told her, you have 3 choices. Now, she had already gone to her doctor and the doctor said, everything's fine. I do not know what the problem is. You got the implants out. What's your problem? She had 3 choices. Number 1, do nothing, pray to God and hope for the best, which is, you rely on faith. Number 2, do patchwork, take some steroids, muscle relaxants, antidepressives, the steroids to calm the inflammation down. And number 3, take that definitive move where you get the residual capsules removed by a surgeon who is an expert in residual capsules, who sincerely believes into removing all the capsules and any inflamed tissue and sending it off. And then anticipating and hoping that this is the last and best option after you have exhausted all these other avenues.
Okay.
Which is exactly what my patient did today.
Do you still have time for more questions? I don't want to.
Yeah, no, please go ahead. Yeah.
Why do so many become sensitive to chemicals after explanting, me included? That was from Heidi.
So why do they become sensitive? Now, I will tell you, what is breast implant illness? Breast implant illness is where the body itself recognizes the implants and goes on overdrive, becomes hyperactive immune system. Now, it's like you have a cold And remember how you're worn out, tired, even though you slept 10 hours and you're still tired and you're like fatigued, right? Because your body is on immune overdrive. Now, when it's on overdrive, it becomes more sensitive to what's it may not have been in the past. Now, this is where I'm just putting the 2 and 2 together, as this has been shown, where now the patient, before she ate ice cream her whole life or cheese, now all of a sudden she has sensitivities to bleach, for example. So now some people have sensitivities as well. The point here is, because of that overdrive, now the patient becomes much more sensitive to what in the past they could tolerate. Now, this needs to be studied, investigated. And if you ask me, this is an immunological problem, a histiocytic reaction, a reaction to an overreaction to what would be a normal stimulus, for example, that the body itself would be able to accommodate. Now it cannot. Be it the gut, be it the smell, or maybe a smell that before used to trigger a small headache, now triggers a migraine, for example. But again, this needs to be studied.
I had terrible issues with chemicals and foods, and I'm 4.5 years post-op, and it's taken all of the 4.5 years to become less sensitive. I still can't wear perfume. My husband can't wear cologne. When I was pregnant, I was extremely sensitive to scents and stuff. And, but it's so bad. Like my friend even put hand lotion on when I was driving the car, and I was just like, what have you done? And I had to pull over and make her go in and wash her hands, and I could still smell it. I said, my lungs just felt like they just, it's in it. And I was never like that before I got breast implant illness. So yeah, it's pretty common. It's a pretty common complaint amongst all the support pages. And I think that was our last question, unless I missed any of them, but I think that was our last one, Dr. Khan. I think this was one of our most wonderful ones, I think, ever. And I just want to say, because you're so passionate, I didn't even get to introduce you because you're so passionate, but I just want everyone to know that I think I met you like 4.5 years ago.
Yes.
And I started a support page in Michigan on Facebook, because when I explanted, there was only 2 doctors. One of them I had never even heard. Well, I didn't hear of either of them, but I ended up going to Costa Rica because I didn't know. And so my whole point, I wasn't trying to reinvent the wheel by starting a support group. My main purpose of my support page is to find doctors in Michigan. And we started out with 2, and now we have 12. But you came 4.5 years ago. I didn't have a clue who you were. And I wanted to put you on my support page, but the women, I get it. They feel like they can't voice concerns or something, so I suggested you start your own support page, and you had, I checked the other day, you had over 8,000, almost 9,000 people on your support page here in Michigan. So you have quickly become one of the top 2. There's 2 of you that are the most popular in Michigan, and you are one of them. And when I saw your support page just skyrocket to over 8,000 women, I hope people realize that it's just in the state of Michigan. I'm not saying everybody on your support page is only from Michigan, but we're being told that this is just a small amount of women. But if anybody who's listening goes on Facebook, you type in breast implant illness, you'll see all the different support pages. Just look at how many people, and these are all women, some of them have men on them too. Look at the amount of people who have joined these support pages who are sick or in the dark and didn't know. And we're being told that this is a small percent. And I totally disagree. And I think it's a silent epidemic.
Yes, no, absolutely. Very well said. Now, I just want to mention, if you look at my practice, and let's look at any of the top 10 or other explant surgeons, I will tell you, each one of us has a unique way of doing it.
Yes, you're all different.
Way, where I will challenge the other surgeon and say, why is it and how is it that this is being done by you, in a way where I question, for example, the lift is being done along with an explant in 3 hours, where I myself take 4 hours on average for every case that I book. Now, having said this, I want each and every single patient, not only to talk to one, but talk to 3, 4, look at and understand, talk to the previous patients, because that's where all your answers are going to lie. This is where you ask the patients and you go and dwell into what is the surgeon thinking, how is he or she doing it, and then you make that sound decision where you're content. Some ladies have taken 6 months, some 3 years to make a decision. This is where you want to do it once, you want to do it right, and you want to do it with that peace of mind and confidence that your surgeon did the darn best job from the goal of removing all implant capsule and all inflamed tissue, and doing a complete workup where the capsule was looked at, the cultures were taken, implants were retarded, pictures were done to show complete removal, and the patient also has what is a good aesthetic ultimate result. And that is what is explant surgery.
I want to say I agree with everything Robyn said when she was saying goodbye to you and she was patting you on the back. And I agree 100% with everything that she said. I think you are a saint walking this earth with us. You are really incredible. The way you spent your own money to warn women. You do Facebook Lives constantly. I know of no other, I've seen other doctors doing Facebook Lives, but I don't see them doing them all the time like you, and dedicating all their time. You've dedicated your own money, and it's constant time that you dedicate to us, and we all appreciate it. And I'm sure there's women out there that really want to thank you, and I'm going to thank you for them, because we really,
Thank you.
really,
I will tell
truly
you,
appreciate
pleasure
you.
is mine. It's a privilege to do something what is right and an honorable, and history will only prove Tracy and Robyn and I, we did our best from our heart, sincerely. Tomorrow morning, you're going to receive so many phone calls. You told me about this one patient, I think 3 weeks ago. She went to her, and I'll end with this. This is a lady, she went to her plastic surgeon, and she ended up finding out later she had what was BIA ALCL. And now she has to go back, get the residual capsule removed, and now she has to go to a medical oncologist, get secondary surgery, likely remove the implants plus the capsule, and now she has to go undergo another surgery, and now to deal with the cancer that could indeed have been avoided.
Are you talking about the one gal?
Yes. And you
Okay,
ended up.
so I'll just explain to people. I can't tell you who she is, her privacy, but she messaged me, and what caught my eye was she had her breast implants exchanged, replaced with a new set. I don't remember the reason why. But when the doctor opened her up, he found all kinds of what was it? Cysts, and then a seroma. And what did he cauterize the cysts or something? And then he left the seroma and said he put the implant in a little differently so it wouldn't hit the seroma. He didn't even deal with it, and then put the implants in on top and thought, things don't look quite right. So he sent it to pathology, but still put a brand new set of implants in to get his money. And then it came back from pathology. Now she's got these new implants, and pathology came back that she's got BIA ALCL, the man-made cancer of your immune system. So now she's got this brand new set in. She already had the cancer before he put that new set in. And so that's what you're talking about. Is that the gal?
Yes, that's,
and now she doesn't have enough money to even get them removed, and they're refusing. Insurance is refusing to pay.
That is so sad and wrong in
Yes.
so many ways. Yeah. Now this is
Do
where
not realize what we go through.
Yeah, and her treatment with the chemo and whatnot else is going to be upwards of $250,000, if not more, if you ask me. This is just walking into the major hospital, because that's where she needs to be taken care of. Chemotherapeutic agents, very likely she'll need to do that with the medical. And again, remember, this has to be done at major medical centers of the US, not at a small community hospital. And now this is what we're talking about. This is the awareness. It was the red flag, a seroma, any fluid collection on the chest is cancer till proven otherwise, because it is abnormal to have a fluid collection, especially when not checked, and this is where it is important and is malpractice to not check. And I'll say those words because that is the right thing to do. Now, this is, I find this talk very, very informative. If you listen to what Tracy and Robyn and I talked about with an open mind, you should have no doubt that the implants are horrible devices. Shockingly, surprisingly, and sadly and shamefully, they're still being put in on a day-to-day basis as if there is no problem with them. And I feel optimistically in my mind that that day is not far. Hopefully the FDA will step up and ban these devices. I'm optimistic. I will continue, and I request my plastic surgery colleagues to stop augmenting and to talk about explantation and to do the right thing and speak in the masses so that we can speak on behalf of the many patients who are hurting, who will only hurt, and that we can prevent this epidemic, pandemic, or whatever you call it, such that the patients don't have to get hurt. And it's not only the patients, but the significant other, the sons and daughters, the neighbors, the society as a whole, so that we can save our fellow beings, if you will.
I call it a silent epidemic because I have friends who have them and they don't appear to be reacting. But what I tell them is you don't appear to be reacting. You could be silently getting one of these two cancers. And that's just such a big concern. And I've always stood my ground because I'm a don't tread on me kind of person. If you want to smoke cigarettes, do it. You want to ride without a helmet on, whatever. And I always say, why would I stand in the way of another woman getting breast implants and take that away from her when she may not react? But after September, when I heard about the squamous cell cancer and 43% were dead within 6 months, it's the first time I'm going to say on the record, I absolutely think breast implants should be banned now. I'm tired of, I mean, I don't want to tread on anyone. I just, in my heart and in my soul, I've always thought they should be banned, but I've always said, do your thing. But I really, truly, truly feel they should be banned again.
No, I agree with you. Do no harm.
Yeah.
That's the oath. That's the oath. Yep.
Thank you, Dr. Khan. I think you're just really a really special human being.
Thank you. No, I appreciate it. No, thanks for
dedicating
those
all your
kind
time.
words. No, thanks again for those kind words. I'll just say this, I'm just doing my job and I do it from the bottom of my heart.
Well, that's not true. You go above and beyond doing your job. No, I don't see any other surgeon dedicating all their time like this. And you're always so gracious. So I really appreciate you. Thank you so much.
You're welcome. Thank you. Thank you very much. Take care. Have a good night. Thanks to everyone. Good night.
Thanks.
Bye-bye.
Bye-bye.
Bye-bye.